The question I'd like to address through this video is whether adding a balloon guide catheter to a combined technique is favorable or not. This 78-year-old female presented with IC occlusion at 3 hours from onset. She had a type 3 arch, and while trying to navigate an Amplatz wire, it caused prolapse of the catheter into the arch. Therefore, a Termo extra stiff exchange length wire was used to take the Walrus balloon up to the distal cervical ICA over an inner catheter. Thereafter, an Amplatz extra stiff wire was used to navigate the Walrus balloon as close to the petrous ICA as possible. Initial injection showed a terminal ICA occlusion. Stent retriever thrombectomy was performed without the use of an aspiration catheter. The balloon was inflated prior to deployment of the stent retriever. Tiki-3 reperfusion was achieved. To understand aspiration, one has to understand how one is able to suck water through a straw. One makes the straw devoid of air and creates a pressure differential, and therefore the atmospheric pressure now pushes the water up through the straw. When the aspiration pump is turned on, the aspiration catheter is devoid of air molecules. This causes a pressure differential between the blood pressure proximal and distal to the clot and within the catheter. This pressure gradient, i.e. the higher pressure within the arterial system, pushes the clot into the catheter, aiding the retrieval. Therefore, one may argue that by inflating the balloon, you arrest the flow in the circulation, and this may in fact reduce the pressure differential and may act against clot retrieval. Therefore, one may stick to a balloon guide catheter that is navigable and a stent retriever for a red clot.